The title of my lecture is as follows, and I'm from the Philippines. These are my disclosures. I declare no conflicts of interest. And I'd like to reach two things at the end of my slideshow. First, I'd like to emphasize the role of pre-op templating as a tool for your students for them to do successful surgery when they're fixing fractures. Second point is that I'd like to show you the evolution of creating the pre-op plan, whether you're using tracing paper, whether you're using an app, or you are augmenting it with a 3D print out or a combination thereof. So the cover of the AO Trauma Principles of Fracture Management is as follows. And not surprisingly, it's about preoperative planning. Because if you don't plan, you actually plan to fail. And these are the problems that we might encounter when we're doing the surgery. And ultimately, we're doing the surgery for the patient, not just for our own fulfillment. So this is how a typical day in my conference room looks like with my residents doing their preoperative plans for their patients. This is what the basic kit features in the templating envelope. And this is what my templating kit looks like. I still use my templating kit from residency up to present. So this is a 44A2.3 injury, and the patient took a misstep, and you can see a bimalleolar injury. And there are many ways to template this. So I still do it using paper. This is just a time lapse of how I trace the fracture fragments. I trace it with colored pens, fracture lines, implants, different colors each, and I have to label what I do for my pre-op templating. So this is the injury, and this is the final outcome of my preoperative template. This is it immediate post-op. This is 1 year follow-up. This is implant removal, and the patient is very happy. EOFA score 96. So I let my residents do their own templating, and they have shifted to an app-based platform. So they're tracing the lines, they've turned off the radiography layer. They're now drawing multiple implants that they're considering of using for this patient. So they're really using a variety of constructs. And the nice thing about the app is that you can turn off a particular layer so that you can use screws, turn on the plate and screws construct, use a tension band plate, whatever they want. The important thing is they can reuse this from one patient to the other patient. So this is the work of a junior resident. This is that of my trauma fellow, and she is very straightforward in just putting cannulated screws medially and laterally, to each his own. Now this is a 4.2C3K fracture. If you look at it quite closely, it can extend to a 4.3A 1.1 injury. So these are ankle and leg x-rays. These are CT scans showing the fracture reduction. And this is stage 1 because there was an open wound for this patient. So we're putting the external fixator, we're looking at the alignment, but post-op, when you look at the overlay, you play around it, there's still a varus deformity. This is stage 2, where we're trying to fix the varus deformity. We're putting the plate, we are doing morphology, and then we're putting the screws. And here you can clearly correct the resident why there is no locking screw or why they're all cortical screws. So this is stage 1 post-op. This is stage 2 post-op. This at 6, you can see the templates matching that of the digital app. And then this at 6 months, this at 1 year follow-up, patient score, EOFAS 96. Now, for more complex injuries, this is a 4.3C3 injury. You have a puncture wound on the anterior distal leg. These are the leg x-rays, ankle x-rays. We choose to show the axial, frontal, as well as sagittal cuts, and you can see the clear pilon injury from the plafond to the pilon, metaphysis, extending partially to the diaphysis. This is the 3D reconstruction. This is the 3D printout. I will get into detail on how we achieve the DICOM file to an STL file to this. And this is the uncleaned 3D printout that I will show you is cleaned later on for preoperative planning for this patient. So the resident prepared plans A and B for this patient. So you have a long medial plate. You also have a plate and screw construct for the lateral malleolus. Plan B, you can see an intermedullary pin and a construct for an hybrid external fixator. These are the approaches or he considered based on textbook. We follow a few textbooks as prescribed text here in the Philippines. This is a 3D printout. You have to chop it off. You have to remove the rafts. You have to clean off the supports. And you can see the pilon resting on the talus. And when you break apart the pilon, you can actually see the quadmalleolar concept of the distal tibia. You can see the lateral malleolus. You can see the Volkmann's fragment, the medial malleolus, the big Tiliushapu fragment for this patient, as well as that pinpoint articular injury, which we juxtapose with the HL CT cut. And if you don't want to do plan A or plan B, you can fix this using olive wires in the hybrid external fixator or Liserov frame. You can also prepare the implants that you have and prepare it before you actually do the surgery for the patient. So this is just the DICOM software. I am about to export it so that I can put it into a slicer app. So basically, we're looking now at the region of interest so that we can narrow down which part of the fracture we want to print out. And we want to narrow it down simply because the bigger it is, the more time it will take to print out. And now we're cleaning off the splint, we're trimming off the edges, we're removing fine comminution so that we don't have to print the unnecessary portions in this file. And we export this as an STL stereolithography file. All of this can be done in a matter of 10 minutes. And this STL file you put into Cura or a slicer app. And what it will do is it will convert it into a language the 3D printer will understand. It's called a G-code file. And this G-code file will be transported or translated into the actual diagram. So here is the printout that's already been cleaned. We can actually print templates. So this is a sample of a template STL that you can download online from the library. It really depends how resourceful you are in finding these, because a lot of my students don't want to pay for these services, but they do them by themselves. So back to the same patient, the puncture wound has healed. We have some wrinkling, a little ecchymosis on the medial mid-leg, the anterior approach. We see the articular reduction. Intra-op, we see that intra-articular fragment, which we put back, and we juxtapose that to the 3D printout that they did before the actual surgery. This is the final construct. We do a lot of shooting just to see the articular reduction. Sometimes you have great ideas of how fixation can be, but the reality with the pandemic is that we might not have access logistically with these implants, and we have to work in an austere setting to be able to fix these injuries. So this is the post-op for this patient. This is the wounds 1 day post-op. We do passive range of motion, and then you can see the flicker on active range of motion. We also do printing of 3D implants simply because a lot of my residents have not seen or touched a titanium plate. So I print these out. So you have distally threaded cancellous screw, an arthroerasis screw, a 2.7, 4.5 cortical screw, and a locking plate. And then you have to clean them up because some holes might still have the supports and rasps from the 3D printing. They're actually printed to scale, so they can fit a screwdriver. And you can actually play around with them, let them feel what the implant is, what the shape is. And they can actually engage with the threads into the plate construct that you've made. And you can print this for each lesson for their learning. And if you're dealing with minimally invasive fracture surgery, you can teach them how you can thread the plate or strip the soft tissue so that the plate can slide in. So we've ventured beyond ankle trauma surgery. So this is also for ankle reconstruction. This is a patient with a bimalleolar injury from 2 decades ago, presenting with end stage with post-traumatic osteoarthritis. This is the right ankle weight-bearing film. The CT scan shows narrow joint space. You see a cyst formation, the pilon. This is the contralateral normal side. This is how my senior resident templates, again, tracing the fracture lines or the injury pattern, turning off the radiography, putting in the implants, and typing in or writing handwritten notes for his surgical tactic plan. And on arthroscopy, you can see the eburnated pilon and the plafond and the talus articulation, provisional pinning after joint preparation. This at immediate post-op, 1 year post-op, and you can see the good range of motion beyond the talotibial joint for this patient. Mobilization is also an issue. It's part of your rehab protocol as well when you're doing your plan. And we've decided to actually do 3D printing of our walking aids. So this is a peg leg. It's free online. And basically you get the STL, you print it again, you put it on the G-code, you have it in the 3D printer in your office, and then you can see the nice product before you. You can paint it, and this is how the patient will walk with it. So to take home, to summarize, I would like to state that pre-op templating is mandatory. It is vital when you're doing surgical fracture fixation. And it's really a reflection of how the surgeon thinks, and it allows the mentor to tell the students what his errors were in his chronology or sequence of surgical planning. And you get to correct mistakes even before actual surgery is done so that you can further prevent harm for the patient. The pre-op plan is a comprehensive document. It goes beyond actual surgery, hence the rehabilitation that you have to include for your patients, not just patient positioning, anesthesia type, marking, etc. Finally, there are many ways to do your pre-op templating. I'm not saying that there's a best method of doing so. You can use paper, you can use an app, you can use a 3D printout, and there's really room for innovation. And I hope that this field will continue to grow. Once again, my name is Chinkin. I'm from the Philippines. Namaste.